Good evening, everybody, and welcome to this evening's Smoking Cessation for People Who Use Alcohol and Other Drugs webinar. We're joined by our presenter this evening, Dr. Hester Wilson, and our facilitator, Dr. Tim Senior. And my name is Samantha, and I will be your host. Before we do make a start, I would like to make an acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past and present. Okay, so I would like to introduce formally our presenters for this evening. So we're joined by Hester Wilson. Hester is a GP and an addiction medicine specialist, as well as the chair of the RACGP Addiction Medicine Network. Hester has a master's degree in mental health and 25 years experience working in the primary healthcare setting. She's also a staff specialist in addiction at Sydney's Langton Centre Drug and Alcohol Clinic and has facilitated training for doctors and other healthcare workers since 2001. Welcome and thank you for joining us, Hester. And we are also joined by our facilitator this evening, Dr. Tim Senior. Tim is a GP at Tharawal Aboriginal Corporation in southwestern Sydney. He was originally trained in the UK. Tim is an RACGP medical advisor for the National Faculty of Aboriginal and Torres Strait Islander Health and a senior lecturer in general practice and Indigenous health at UWS. So welcome, Tim and Hester, and thank you for joining us this evening. All right.
Good evening, everyone.
Perfect. So I might hand over to you now, Tim, to take us through our learning outcomes for this evening, and then we'll jump over to Hester to get us started.
Lovely. Thank you very much. Good evening, everyone. Welcome to the coronavirus-friendly social isolation CPD webinar. I hope you're all staying well, and even though we're all taken up by coronavirus, this will be a coronavirus-free zone because we still see patients with all our other problems. So what we're going to cover tonight, we call learning outcomes, and this is just describing what we hope to get out of tonight. So by the end of this activity, we should be able to recognise the high smoking rates among people who use alcohol and other drugs and the importance of addressing smoking in this group. We should be aware of the common barriers and debunk the myths around quitting and recognising the factors and opportunities for smokers to quit smoking. We should be able to discuss tobacco treatment options and provide advice on the usage of different forms of pharmacotherapy and understand the possibility of the drug interactions with quitting smoking. And we should be able to provide practical support and tips related to smoking relapse prevention, including using specialist information to identify referral pathways and options for continued smoking cessation support. So we've got a lot to cover tonight, so let's move on to Hester.
Hi, everybody. Look, we've got a lot to get through. There's a lot of slides. I do want to just acknowledge, first of all, Diaz Soweto, I'm sorry, Diaz, who actually put these slides together with her team at New South Wales Health. So thank you so much for assisting us with this. We've got a lot to get through. I'm going to move through quite quickly. The slides will be available. There's lots of fabulous information on them, so I encourage you to go back and have a look after we finish up. But I wanted to start with Simon, age 45. So he's someone, you know, imagine this as someone that you've seen in your surgery. You know him and his wife and children well. He says, I need to give up smoking. My son came home from school and has begged me to give up, but I've tried a few times and I never succeed. And he has a few drinks with his mates on a Friday night, and in fact that's 12 to 15 schooners, which is, you know, closer to 20 standard drinks, and also often Saturday nights as well. He shares a bottle of wine with his wife, and he says, look, I do drink most of the bottle. His wife is supportive of him stopping. He also smokes cannabis with his tobacco, probably monthly. And so just thinking through, is this the sort of patient that you guys might be seeing, and what are the issues that you might see with this? Have a think through that as we move on through the slides. So bottom line, people who use alcohol and other drugs are more likely to smoke and smoke more heavily. They tend to start at an earlier age, and they tend to smoke over a longer time, and they die of smoking-related illness. In the clinic that I work in, 86% of our patients smoke, and that's in comparison to 15% of the Australian population. What we sometimes think is that people who use other alcohol and other drugs don't actually want to give up smoking, but the truth is that they do. They do want to stop, and it improves their recovery outcomes, and we can help them do it. But they need more assistance, not less. Change, yeah. Yeah, so range from 68 to 98, and certainly in my group it's 86. And you know, it is uncommon if we're seeing somebody who has a substance use disorder, be that alcohol or opioids or benzodiazepines or cannabis or methamphetamines, cocaine, other drugs, it's uncommon to find someone who doesn't smoke. I'm always a bit surprised when I ask that question and find that people don't smoke. And the thing that I always say to people is that, you know what, nicotine is one of the most addictive drugs and it's the hardest to give up. And certainly we know that there is a genetic predisposition that leads to the dependence, and certainly the same pathways in the brain are kind of shared between nicotine and other drugs. I have to flag though that that is not the full story. So looking at that biopsychosocial approach to people's lives and their health and well-being and their alcohol and other drug use is much broader than that. But certainly dopamine, it's a happy hormone. It creates pleasure and enjoyment. And this is one of the things that nicotine does. When you have a cigarette, it brings up that dopamine and makes you feel better. But as I've said before, the relationship between tobacco and other drug use is quite complex, and we'll talk more about that. Next slide. One thing that's really important to think about is that in some people, they have a different rate of nicotine metabolism. So those fast metabolizers will tend to be more addicted. They have increased risk of harm. They crave their first cigarette on waking, and they'll be the ones when you ask them, how long after waking do you have your first cigarette? They'll say, I've got it rolled up by the bed, ready to go as soon as I wake up, or even I wake during the night to have a cigarette. And they find it harder to give up. That doesn't mean that they don't want to, and that doesn't mean that they can't do it. They need more support. Moving on to the next slide. So polycyclic aromatic hydrocarbons, the PAHs, really are the big issue here, and there are 4,500 different types in tobacco. And they're the carcinogenic substances and toxic substances, and smoking leads to health effects in just about any organ in any part of the body that you can care to mention. The other thing just to be aware of is people that smoke tend to drink more coffee, and people that drink alcohol tend to drink more than the non-smokers. So if you're a cigarette smoker, you'll drink more caffeine and you'll drink more coffee. We will talk about medications because this is a really important thing to be aware of. And look, here they've mentioned antipsychotics, anticoagulants, pain relievers, and insulin. But be aware that smoking tobacco affects the metabolism of a lot of medications. And when people stop, you've got to keep an eye on those medications, and quite often you can cut the dose down because they don't need as big a dose. And that can be a really nice thing when you're working with people, to be able to work with them. Well, they're on methadone, we can cut the dose. They're on antipsychotics, we can cut the dose once they stop their tobacco. Next slide. So cigarettes and alcohol together add to that happy hormone dopamine. And certainly, once again, drinking alcohol, there's the whole kind of dynamic there of having a drink and a smoke, and the genetic predispositions and neurological effects there. Smoking counters those cognitive effects of alcohol and reduces severity of alcohol withdrawal. It's not a great treatment for alcohol withdrawal. And we also know that the risk of cancer is increased. Smoking tobacco causes cancer, as does alcohol. Cannabis users, very few cannabis users don't use tobacco as well. There are some, but quite often they will use tobacco with the cannabis, either in their joint or in their bong. It gives a smoother smoke. Because the tobacco inhibits your cough reflex, you don't cough as much when you use your cannabis. So the issue is that you have a double whammy there of dependency with cannabis and tobacco, and quite often people focus on, I've got to stop the cannabis, it's the cannabis that's the issue. But if you don't pay attention to the tobacco, it's the nicotine dependency that can continue, make it difficult for them to change that. So it's always, when you've got someone that's using both cannabis and tobacco, help them to quit both. Once again, with the stimulants, we're talking methamphetamine, amphetamine, or speed, and cocaine. People using cocaine tend to smoke more, and more nicotine means you use more cocaine. Opiate users have the highest smoking rates. As I say, in the group of people that I work with, it's 86%. Methadone is affected by cigarettes, and cigarettes are affected by methadone, and they tend to smoke more heavily. Certainly because with nicotine, tobacco, you increase the metabolism of methadone, so they might need a bigger dose, but it also reduces sedation. The other thing, of course, to think of with many people who are using opioids, that they have higher levels of psychiatric distress or comorbidity, and smoking to some extent is an antidepressant. We'll talk more about that because it's not a particularly useful antidepressant, but given that it raises those dopamine levels, it's an important thing to consider with your patients. Moving on to the next page. So why should smoking be addressed? I mean, that's a bit of a no-brainer. You know, we know that smoking will kill 2 out of the 3 people who continue for some time. It affects every part of your body in an adverse way. And in the group of people who use alcohol and other drugs, quite often they've started smoking earlier, they smoke more heavily, they're at higher risk, their health issues are profound, and as a result, they have higher morbidity and they die much earlier than other people in our community. Reduce the effectiveness of some medications, as we've seen, and stopping smoking can actually improve treatment outcomes. It can be a gateway to illicit drugs. Oh, I don't know. I don't know if I entirely agree with that. I mean, I'd kind of say that in a way, you know, use of illicit drugs leads to continued smoking. But certainly that relationship between smoking and using other drugs very clearly. If you've got a smoker, you need to ask about other drug use. If you've got someone that's drinking a lot or using other drugs, then always ask about the smoking, because you're likely to find that tobacco and nicotine dependency is part of the picture. Moving on. Can alcohol and drug users, so people who are using alcohol or other drugs, whether it be harmful, hazardous or dependent use, they can quit smoking. Absolutely, absolutely. The issue that we have is that they find it harder and they need more support, not less. And it's certainly something that I've seen, is this kind of nihilism that we as health workers quite often have with somebody that is using alcohol and other drugs. Oh, they don't really want to give up. They actually do, and we need to put more effort in, not less. They have better outcomes. If they stop, their mortality and morbidity will be very positively affected. So it's a really worthwhile thing to do. But long-term quit rates are low. And in a group of people like this, it might be that they give up smoking 20 times in their life. But I always say to people, every cigarette that you don't have is doing you good. Every day that you don't smoke is doing you good. And there may be people who say, look, I'm not ready to quit right now. It's important for us to continue to have those conversations, to continue to flag, I'm concerned about you smoking. When you're ready, I want to talk to you about this. I will continue asking you because this is really important. And it's one of the things for me that I see quite a lot. We work really hard, people work really hard to get their lives back together, to stop their injecting use, to get themselves on a program, to get themselves housed, get into work, and 5 years down the track, they're doing really well, but they're still smoking. And it really concerns me that at that point, they're still smoking. And we really need to be working with them to actually change that, because that's what's going to kill them. Moving on. So there is some issues with tobacco, you know, the idea that tobacco is not a real drug. Well, it is. Nicotine is, it has receptors. We have the same issues as, you know, it is a drug of dependence. And smoking actually doesn't reduce stress. Now, and that is one of the things that is an issue quite often, that smoking helps my mental health. Actually, no, it does not help your mental health. It will make your mental health worse. And when you give up and when you stop, your mental health will improve. As we've said before, health professionals, and there's a lot written in the literature around this, well, patients aren't interested. They are. The other thing is, oh my goodness, it's too hard to address all substances at once. And this is a tricky thing that I'm always talking to my patients about. And very commonly people will say, no, I can only cope with changing one thing at a time. And you need to work with where your patient's at. But the reality is, it can be really effective for people to stop all their substances at once, to make an attempt to change that entirely with good treatment, not cold turkey, but with good treatment to help them change what they're doing. people do worry, you know, like, oh God, I won't be able to stand the withdrawals. That's why we have good treatments, and they can make a difference to that. You know, and it's going to make me more unwell. There have been a lot of concerns, particularly with people that have major mental health issues, that it will undermine the recovery from their and make their mental health issues worse. In fact, it makes it better. But just flagging, if you've got someone that has a major mental health issue, you do need to follow them up and see them quite frequently. And we'll talk more about that as we go to the medicines and treatments that are available. Next one. Okay, so the barriers. So for patients, if you're very dependent, you're going to need lots of support to actually change that dependence to nicotine. Conflicting drivers. So for people, look, you know, I enjoy a cigarette. And getting them to think about what that actually means. Is it that they enjoy it, or is it actually that it relieves their withdrawals? If they're in a community where everybody smokes, where the way that things happen includes smoking and it's part of the social scene, that's really can be difficult. And that's particularly an issue for people in the Indigenous communities, where smoking is seen as part of a kind of a community activity. You know, people have tried before and have failed, and that sense of failure, I can't do this, this is too hard. Really working with them around what quitting actually means and what it looks like, and we'll come back to that in a moment. If people are actually really unwell with chaotic or problematic use and other things in their life are falling apart, you probably need to help them get back on track. You know, so it may not be the right time while they're withdrawing from their alcohol or you know, getting themselves housed. And the reality is that this is a group of people who actually access less support when in fact they need more. Moving on. So, as I've been saying, it's part of our role to advise smokers to quit. We know that concurrent or combined treatments, so that is combined NRT or even using varenicline and NRT, actually make a difference. They help people quit, and they help people to quit long term. Tobacco and difficulty quit smoking, yes, it may be more difficult for someone that's highly dependent, but there are good treatments that can help them do it. And once again, just flagging, you know, do ask people about their caffeine and their alcohol use. Encourage them, use positive affirmations. Some people can be useful to talk about the financial benefits from quitting smoking, while others, they just get really depressed. They think, oh my God, I've wasted all this money, and then that makes them want to have another cigarette. Looking at the other things they can do, quite often could be really useful for people to think about, okay, I'm going to do the detox, I'm going to get to the gym, I'm going to make these other changes, I'm going to change my diet, I'm going to do that with my partner, with my family. You know, and certainly for our fellow whose child was saying, Dad, I want you to stop smoking, that can be a really great driver in terms of family supporting and helping him to change what they do. And people can have this really kind of black and white, I've got to quit, I've got to stop and never do it again. And that can feel impossible. So really working with patients individually to look at, well, how can you manage this change? What can this look like for you? And what can be success? And success can build over time. Next page. So we're going to talk a little bit about the 5 A's, the pharmacotherapies, hospital-based smoking cessation, quit smoking, referral to Quitline, I Can Quit, educational interventions and tobacco control legislation, which is interesting. I would also add to that, looking at the apps, smoke-free apps and other supports that are a little bit more kind of, I guess, novel. Moving on. The most effective treatments are pharmacotherapy and support and counselling, behavioural treatments. And that doesn't need to be full-on stuff. It can be the conversation that we have in general practice, but just flagging for people who have very strong dependence and find it difficult to make that change, that additional counselling can be really useful. As I say, they need more support, not less. So that means for us as GPs, following them up really regularly, looking at the other supports that they can put in place to assist them to make the change. So with your counselling, helping them to look at what are their triggers, what happens when are their at-risk times for smoking, what are the things that are really important to them around changing their smoking, and where can they go for support. Pharmacotherapy is great for managing cravings and withdrawal symptoms, and we'll talk more about those in a minute. And of course, you've got the smoking cessation services. Older people like those, younger people like the more novel online options, including the apps. And really remember that you're going to need to tailor the treatment to the patient that you're seeing at that time and their situation. Moving on. The 5 A's approach. Now, I'm assuming that the vast majority of you have heard of this. There's certainly the SNAP guide, the Smoking, Nutrition, Alcohol and Physical Activity Guide, which goes through, and really when you think of it, the Ask, Assess, Advise, Assist and Arrange really are what we do in a consultation. So we're screening, we're making an assessment, we're giving support and information, we're assisting with medications and other treatments, and we're arranging to follow up. I just want to flag, with smoking, I don't actually do the 5 A's. I do a much shorter one. I give very brief information. And this is, I think, really something that I want you guys to take away, because one of the things for us in general practice is that we're always busy. We've always got lots of things to do. So if you haven't got a lot of time and you think, oh, geez, I don't have time to do the 5 A's and start the whole smoking thing, you can, in this situation, in 15 seconds to 30 seconds, you can do a really quick approach, which is checking in, first of all, do you know if they're a smoker? So asking them if they're smoking, or are they still smoking? Or if they've stopped, are you still stopped? And saying to them, now I just want to let you know that of course there are really effective treatments for smoking. Are you interested in having another go? Can we make another appointment? I don't think you even need to talk to people about the risk. They all know that smoking's bad for them. They are all really likely to want to make a change. It may not be now, it may be in the future, but with that very brief advice, you're just saying, just reminding you there are really brilliant, effective treatments. Can we make another time, or can I refer you on to a smoking cessation service to start making this change? And there's your intervention done in 15 seconds, 30 seconds, and then you can make another time to follow up with them to go into it in more detail. Moving on. We're going to move on from that. Once again, so they're interested in quitting, beautiful. Advising the harms and the benefits. Once again, I would suggest that they probably already know that. Sometimes with younger people, you might think, geez, maybe they may not, we're not going to go for the lung and cardiovascular harms. It might be the stuff around fertility or bad breath or teeth or whatever. But looking at the medications, looking at the treatments, we've got medications and pharmacotherapy, and we'll talk about those in more detail. Healthy lifestyle, as I mentioned before, getting out there and having some exercise, and healthy eating, changing your caffeine and alcohol, and looking at the New South Wales Quit Line, Aboriginal Quit Line, which is fantastic, and they can give counselling, telephone support, the I Can Quit website, the apps and other supports that are out there online as well. And as I mentioned, following up, arrange for follow-up, and with people that are highly dependent, arrange it soon. You might arrange for it later that week, or you might arrange for it in 1 week's time, but be aware that you want to be there to support them through that. And so that if they have the lapses, if they slip up, if it doesn't work the first time, then you're in place there to support them to continue making that shift to not smoking. Moving on. Okay, so just withdrawal symptoms, just so that we really are aware, DSM-5, it links the ones on the left there. So the anxiety, irritability, difficulty concentrating, appetite, restlessness, depressed mood and insomnia. The other ones that we see really commonly are cravings or urges to smoke. The tiredness, hunger, craving sweet foods is a really common one. Mouth ulcers, constipation, cough, nausea, sore throat. So a number of those are things that you may see that people may not actually realise is part of their withdrawal. Moving on. Most relapses occur within the first 3 months after smoking. Any smoking the first 2 weeks likely to fail? Well, let's have a think about that. It depends on how you set up the quit attempt. And for some people, total abstinence, the not even a puff rule, can be really, really useful. However, if you have someone that has tried that in the past and not succeeded, you might choose to do it a slightly different way. Excuse me. One Once again, alcohol and smoking do go together. So really looking at, can you stop your alcohol for a couple of weeks just to give you a break? If people can do the not a puff rule, their physical dependence on nicotine will pass in the first 2 weeks if they don't smoke at all. And we know that's really effective. So they want to avoid those places and the times that they're triggered. So alcohol or smoky places or hanging out with other people that smoke. Caffeine or any form of caffeine, once again, encourages you to smoke, and thinking about the things that are particularly triggers for them. So when they get on the phone and talk to their mates, it might be that's the time when they have a cigarette. When they're having a break at work, they've been super busy and they go out and have a smoko, that's the time when they will be triggered to smoke. So if they can give up with the not even a puff rule, that first 2 weeks is brilliant. They get through the nicotine, the physical nicotine withdrawals in those 2 weeks. After that, they need to continue to be aware of the psychological triggers to actually smoke. Moving on. If they have a lapse, once again, they will tend to say, geez, I failed 100%. And what I'm always doing with people is going, okay, so how many days did you manage to not smoke? And what did you do in that time that you were not smoking that you can use to build on this? You had success for the number of days or the weeks that you managed to not smoke. That is totally brilliant. How can we build on that? You know, and that it can take up to 20 quit attempts before people stop and maintain that long term. You know, as I say, it's, you know, every cigarette that you don't have is doing you good. Every day that you don't smoke is doing you good. The other thing is that smoking can be really different. Quit smoking attempts can be quite different each time people try. So just because they've had an experience of it being really difficult in the past, it may not be the case this time round. At the same time, you want to learn from the issues that they've had last time they tried to support them through this time. Moving on. Quitline, really, really brilliant. Great place to go to get some support. And there's the referral things there. We'll move on from that. You can go back to that for your patients when you need it. So a successful quit attempt. The prescribed cessation medications, once again, need to be clear on the contraindications, but pharmacotherapy is the basis of smoking cessation, of changing nicotine dependence. It works so much better than cold turkey. Cold turkey is setting people up to fail. And certainly, you know, that first line pharmacotherapy, nicotine replacement combination, rather than just single, and understanding that combination is not, and both of those aren't both subsidized. You need to buy the oral options. Varenicline alone or combined with NRT, or bupropion alone or combined with NRT are your first line options. Behavioural support is important there, and that can be quitline, that can be seeing you, that can be seeing your nurse, following up to ensure that people are on track and there are no issues that they're coming up again, and supporting them, being a cheerleader to help them make that change. Moving on. In combined use of pharmacotherapy is more effective than single. So combined NRT, and that's what we mean with the patches and the other forms, whether it's the inhalator, the lozenges, the gum, they are really much better used in combination with NRT. And varenicline or Champix is actually the most effective form. It's slightly more effective than combination NRT. Bupropion is second line, really. I don't use it very often, and you do need to just be aware that it can decrease seizure threshold, so be careful in your heavy drinkers, anybody that has a seizure history. Moving on. So pharmacotherapy is supported through the PBS, but unfortunately, you cannot get both NRT and varenicline. You cannot get both patches and oral forms. Aboriginal people do have access to free NRT through Closing the Gap. Now, when you look on here, you'll see that we've got the 25, we've got the 15, we've got the 5, we've got the 21, the 14, and the 7. I have to say that there is no point, from my point of view, using those lower doses. Generally, I go for the 21, 24 hour, and I get people to put it on and leave it on 24 hours a day. The 25s can be useful. Sometimes people will talk about when they're trying to give up smoking, that issue with getting really vivid dreams. I have to say that I think for most part that is actually a withdrawal symptom, but some people can't tolerate it, and for some people the 25, 16-hour patch may be better. But don't bother with the smaller doses. They really are not useful for people that are highly dependent. The oral forms, the gums, the lozenges, the inhalers are also available, and I suggest that people always use combination. So get the patch on the PBS, and then buy the gums, lozenges, whatever suits you. You keep the patch on, and every time you have a craving, you use the oral forms of NRT instead of having a smoke. Okay, look, there's lots more information on the PBS schedule if you wish. Hello?
Hello. Yeah, we've just had a few questions come through, and now might be a good time. So, if a patient wants to do cold turkey, should that be encouraged or discouraged?
Look, it just doesn't work. It really doesn't work. Their chances of giving up are about 3%. And so if people are saying, you know, fair dinkum, I've done it before, I want to do it again, I'd say, okay, look, have a go. Generally, that is hard for people, and in this group of people, it's really tricky. If they want to have a go, absolutely, and there will be people that do manage in that 3%. There are 3 out of 100 who will manage it, but I would be really flagging it's really tricky, and there are really good treatments. So if it doesn't work for you, I want to see you again so that we can offer treatments.
Yeah, excellent. And if someone's trying to quit both smoking and alcohol, can we use pharmacotherapy for both of those?
Yes.
Yeah, excellent.
Absolutely.
And another question about weaning onto weaker patches. Is it worth weaning onto weaker patches?
No point. No point at all. There is no evidence that you need to cut down. The evidence is that you have the bigger patches and you continue them. You've got 3 months of patches on the PBS, and sometimes people need to continue them for a longer period, but there is no evidence that cutting down the patches to cease makes any difference to relapse.
Excellent. And there's a question that regularly comes up, and I wonder if this is different for people with other alcohol and drug use as well, about pregnant women who are trying to quit smoking and using pharmacotherapy for that.
Yeah, fantastic. We will come to that because it's super important.
Lovely. Thank you very much.
Moving on. Okay, so nicotine replacement works by relieving cravings and withdrawal. So it replaces some of the nicotine, but it is not like having a smoke. It is not like having a smoke. The longer people use it, so you encourage them, even if they've had the patches and they say, hey, look, I've been 2 weeks and I've stopped, keep using the patch. Keep using it for the full 3 months, because they may well relapse with the patch. It helps them to stay quit. Approved by the TGA, so you can use the patches in pregnancy. You know, look, the issue with oral NRT, it can be useful, particularly in people that have a low dependency on its own, and when they crave, then they have some gum or a lozenge. But the reality is oral NRT is not as effective as a patch, and combination patch and oral NRT are even more effective. Some people will notice that they have some side effects from the patches, and the gum tastes disgusting and can make them feel a bit nauseous. The inhalator can work well for some people. Sometimes it causes some irritation, but really side effects minimal, not an issue. Sometimes people will go, oh my God, what happens if I have the patch on and I smoke? It is such a tiny dose that they're not going to have a problem. Now, this is a really great graph, because what you're seeing here is what happens with a cigarette. Okay, now this is only 1 to 2 milligrams, and I want to flag here that people will talk about going down to a lower milligram cigarette. Complete waste of time. The way people smoke will affect how much nicotine they get delivered. So if they are someone that draws it in and sucks up really effectively, they will have a much higher level of nicotine than someone that just has a little puff and then the rest of the cigarette smoke goes out into the atmosphere. But what you can see here is there is no way that any of these, the NRTs, actually replace the cigarette entirely. So It's really important to be saying to people, you know, that the sprays are slightly better, but they won't give as much relief. So this is when we look at, you can see with the pink one, we've got the Nicobate 21, which is one of the nicotine patches, very slow onset. It's not like having a cigarette. It doesn't give you that lovely lift and that lovely hit. It doesn't hit the back of the throat and give you that lovely feeling. And it's important to talk to people about this and to say they can help with cravings. And I always say to people, you know, the patch is your background that helps you to not want to smoke as much. And then the oral forms do about 30% of the craving, and you've got to do the other 70%. So it will not feel the same, but we do know that this works and it helps people to give up much more effectively than on their own. Moving on. Okay, avoid underdosing. From my point of view, you really can't overdose, and there's some more slides that we'll look at about using multiple patches. Combination NRT, the patch and the gum, really safe, better outcomes, and really reassure your patients when they say, oh my gosh, I'm scared that I will overdose on nicotine if I smoke and use the patches and the gums. No, you won't. It's okay. The only way you can overdose on your patch is if you squeeze out all the nicotine, stick it in a syringe and inject it into your veins. Then you might have an overdose of nicotine. Other than that, you cannot overdose on these substances the way they're taking. Night patching. Sometimes this can help if people really have that very strong urge to smoke on waking, is to put their patch on at night before they go to sleep so that they have the peak just when they get up. Really, from my point of view, it's around putting a patch on at a time that you remember is more important. Don't stop too early. Once again, continue with the patch for as long as you need. Of course, it goes off PBS after 3 months, but if people are having success and want to continue it, it is okay to continue it for some months. Next page. So Renee Bitoon, I don't know how many people know her, an amazing respiratory physiologist who's done a lot of work in this space. And this is a really great way to look at it, particularly with people that are highly dependent. Now, in terms of people that are highly dependent, once again, I mentioned, you know, the thing that we've always been taught to ask is how many cigarettes do you have a day? That can give you an indication that they're a smoker and can give you some indication of their level of dependence. But the single most important question you can ask is how long after waking up do you have your first cigarette? And if they are the person that has a cigarette, they're ready on the night table, light it as soon as they smoke up, within 5 minutes of waking, within 15 minutes of waking, they are more highly dependent. The other thing that I love, and not many GP practices have this, but to get a CO monitor, a smokealyzer or one of those monitors that actually looks at the carbon monoxide in people's blood, great biofeedback. People use it. You can, you know, people can have carbon monoxide of 50, 70, 100. Non-smoker is kind of 2 to 3 or up to 5 if you live in a polluted environment. It's a great thing that you can use with people so they know when they start that their CO was, say, 30, and when they start changing their smoking, it comes down. It's a great feedback tool. But coming back to this algorithm, basically you start somebody on one and on a large patch, the 21, 24 hours, you know, just before sleep, change each night, and within 4 days, have they stopped smoking? Fantastic, continue on the patch. If they've reduced but they're still smoking, add in the gums, add in the oral forms. If they're still smoking and it's more than 10 a day, if it really hasn't shifted that, add a second patch and put it on daytime only. And then if they're still smoking, then go back to the lozenges. Once again, there have been times where I've actually used more than 2 patches. You know, for someone that's highly dependent, you may go to 3 patches. And then certainly Renee would say, look, you just keep going until people become nauseous. The issue here is that you can't get additional ones on the PBS, so you are looking at people having to pay for it. But once again, using more than 1 patch is very, very safe, particularly in this highly dependent group. Tim, you're going to ask me a question.
I am, which links in very nicely with that. I've just someone asking about what the cost of patches are over the counter and on PBS.
Yeah, so PBS, they are the cost of a script, and if you're on a healthcare card, I believe that's $6.60. In terms of buying them over the counter, they're a bit cheaper than buying cigarettes. Don't quote me on the price. It's been a while since I looked at what the over-the-counter cost is, but they are totally available over the counter. One of the interesting things, though, is that if people get these over the counter and don't get them through their doctors, they don't do as well. There's something about that therapeutic alliance, that engagement, the support that happens with seeing a doctor or seeing a healthcare worker to actually change your smoking that improves outcomes. So yes, you can't get it on PBS, but it is worthwhile looking at, well, am I going to use more than 2 patches if this is really not helping?
And it's
The
3
other
months
thing,
supply, isn't it?
3 months supply through the PBS in a 12-month period. Yeah, that you get on the PBS. The other thing is just working with people around, if they really have very low confidence, it's around, okay, don't even try to stop smoking. Don't even try to change it. Put a patch on. Put a patch on and see what happens. And it's very commonly they'll come back and they'll go, well, I've just put the patch on, I didn't bother. But you know what? I didn't have a cigarette until 2 hours after I woke up. They've dropped their nicotine use, they've dropped their tobacco intake, they've dropped the harmful amount of chemicals that are going into their body just by doing that. And so that is a success. So you can say, that's brilliant. That means that the level of your smoking has gone down. Now, the nicotine dependence has stayed the same. You've replaced it with the patch, but they've made a really important change to how they smoke. And if you've got a CO monitor, that's a great time to say, look, it was 30, now it's 15. You really have made a huge difference. And that can actually build their confidence. Okay, so can you now put off your smoking for 3 hours? Can you add in some oral alternatives, the lozenge or the gum or the inhalator? Shall we add a second patch and see what happens? People do have a whole kind of story around its willpower. I've just got to commit. I've got to have the motivation. And the fact is, this is highly addictive stuff and it's really hard to change. And if we can build people's efficacy with this support, they actually do better. Moving on to the next page. The time. Varenicline. Varenicline on its own has the best odds ratio of all treatment. It's a really good treatment. There are no known drug interactions. It doesn't work for everyone. And if you've got someone that doesn't smoke every day, it perhaps doesn't work so well. And once again, the same with NRT, the longer you use it, the better the outcomes. So it stops the cravings. It's really, really great. Moving on. And combining NRT and varenicline, it's not a great deal of evidence, but it may improve crit rates. And it's certainly something to think about. The issue that you have is that you can't get both of them on PBS. There has been a lot of concern about varenicline and the fact that it destabilizes people's mental health and it causes more mental health issues, particularly in people with enduring significant mental health issues. It actually doesn't. There isn't good evidence that it does actually destabilize. However, I always talk to people about the fact that because the thing with varenicline is it stops the craving, but it doesn't stop the nicotine withdrawal. So as you are changing your smoking, you can find that you're a bit more irritable, and that's because you're changing your smoking. So let's keep a close eye on you. Let's make sure that you're doing okay. So I might see them if I'm concerned. I might see them more often, and I would certainly consider adding an NRT to help with the withdrawal. And the other thing is varenicline may well have a role in changing alcohol and alcohol consumption in heavy drinkers. At the moment, it's not recommended for pregnant and breastfeeding women and for adolescents. Hopefully over time that will change, but it's one of those things where we just don't have enough evidence yet for it to be used in that group. Nausea is the big thing. And sometimes it means that you start off with with the low dose, so with the starter pack, and you build up the dose. And for some people, you can never get up to the full dose, or they need to have antiemetics, things like Maxolon, but it is an issue. Sleep disturbance and vivid dreams really aren't a side effect of the medication; they're more a side effect of the withdrawal. And so that's a really important thing to let people know. This is really likely to be your withdrawal. Taking some food may help with the nausea. Taking the tablets 8 hours apart might make a difference to the sleep disturbances. I haven't really actually seen that, but adding in the NRT can actually help with the withdrawal. Moving on. So this is really important because it is an issue that I know came up in my practice when we first started using varenicline, this sense that it made people really irritable and depressed and aggressive, and there was more suicide. There is no evidence that it's actually the varenicline. Any kind of issues that happen are actually due to the nicotine withdrawal. It's for people that have a history of psychiatric disorders, and for those that don't, there's no difference. But once again, if you have someone that has serious psychiatric illness issues, keep a close eye on them and let them know. And we'll talk more about how you actually use varenicline, I hope, at some point in this, because there's some really interesting ways that you can use it, particularly in this group. You know, and say to your patient, if there's anything happening, any kind of unusual mood or behavioural stuff, we really want to know because I want to support you through this. Once again, avoiding alcohol is a really good idea during this time. Moving on. So here we go. So here's a flow chart. Once again, you get your first script. Don't pick a quit date. And certainly the literature from the company that makes this may well say, you know, quit on day 8. And that can work for some people. But what I would usually do is say, just start it and see how you go. And so you can do a quit on day 8, you can do a cut down to quit, or you can do a quit date anytime during the time that they're using their varenicline, generally within the 4 weeks. But sometimes it can take a little longer, you know, and it's really individualizing it for your patient and for their particular situation. So you may find, and this is really common, I say, just start taking it and see what happens, that you'll see within 4 weeks that they're still smoking, but they've really reduced. They're not drinking, they're not smoking as much. They've got a longer time after waking before they have their first cigarette. They're really not enjoying their smoking. And when you check their CO monitor, it's gone down. And it's such great feedback for people that they've actually made a change. What they're suggesting here is if people actually are still smoking by about 6 or 8 weeks, that you add in the NRT patch or the oral NRT. Some people I might even use it sooner, and really it depends on how things are going. You know, so if it's no effect and the patient is still smoking the same amount, perhaps varenicline is not going to be useful for that person, and you'd probably stop that one and move on to combined NRT. And once again, you have with this medication under the PBS, you have up to 6 months that they can continue on in a calendar year. So once again, the longer people stay on it, the better their outcomes are in terms of stopping smoking. Moving on. Bupropion, we'd used this for a period of time. Overseas, it was Wellbutrin, which was an antidepressant, but licensed here for smoking cessation, Zyban. And Zyban came out before the others, used a little. It's not as effective as the others, but it's something that you could try if they didn't respond to the others. But please be aware of the history of seizures, eating disorders, that you don't want to put them on it, particularly if they're on a Mayo or even if they're on another antidepressant. Can't use it in women who are breastfeeding or pregnant. Moving on. I have to say, so in terms of bupropion, I haven't used it in a very, very long time. Some more warnings around use with other medications, alcohol use, and the drug interactions. So I'll leave you to read that after the show. Moving on. So Jody, age 28, 12 weeks pregnant. So she's stable on treatment for her opioid dependence with a stable dose of buprenorphine sublingual. So 14 milligrams, which is a fairly middling dose. She's on buprenorphine mono because she is pregnant, and she's been smoking since age 13. So first of all, it tells us something really important about Jody. Any child that starts smoking at age 13, you have to wonder about what's happening for that young person, that they're smoking at age 13. What's the cultural background? What are the mental health issues in the family or in the individual? First cigarette within 5 minutes of smoking, and she's smoking 25 a day. So I know from this that this is a person who is going to be highly dependent and is going to find it tricky to give up, but she's pregnant and she's likely to really, really want to change this. You know, pregnant women absolutely want to change this. They can be as dependent as anything, but this is something that they really want to change, and it's really important to support them and support them really strongly, because it's going to make a difference to them and to their baby and to the well-being of the newborn if they can stop smoking now and continue to not smoke once the baby's born as well. So just thinking about how we might help Jodie, moving on to the next slide, and this answers the question before. Yeah, really, really important. I really, really strongly support quitting smoking in the women that I see who are pregnant. And they do want to stop. It might be really tricky, but they do want to stop. And one of the things that can be tricky for pregnant women is that they feel so shameful about the smoking. And if you have any kind of judgment around, no, you shouldn't be smoking, that's bad for the baby kind of approach, they feel so shamed that they will actually not want to engage. So it's really turning that around, having a really positive spin. You know, there are evidence-based treatments that can help you with this. Let's get it happening. Counselling, behavioural treatments are really important, and NRT. Now, in the women that I see, I don't actually wait to see if the behavioural strategies are unsuccessful with somebody that's 12 weeks pregnant. I want to get into the NRT straight off. You know, and certainly financial incentive, you've got a baby coming, this is going to make a huge difference to the costs for your family. And the other thing is just thinking about smoke-free home and cars. Is their partner smoking? Can they give up together? If anybody smokes, they need to smoke outside the household. If she cannot totally give up, you know, want it to be as low as it possibly can. And if she continues to smoke after the baby's born, only smoke outside with a change of clothes so that you're not exposing the baby to passive smoke. But ideally, helping them to give up at this high risk and high motivation time. Moving on. NRT is not the first line of treatment. Well, you know, certainly in this group, absolutely, behavioural measures, if they work, fantastic. But the bottom line is that NRT in a highly dependent woman, yes, you are replacing nicotine with nicotine, but you actually want them to stop, and you can get them to stop using that. So really, you know, yes, it is not first line, but in a highly dependent woman, I would be moving to it very quickly. Generally, we would start with the shorter acting ones. We're trying to avoid the amount of nicotine that the baby is subjected to, but the reality is if they're smoking, they're subjected to the nicotine anyway, and the other 4,500 polyhydrocarbons that are an issue. So I would, with some women, what I'm looking at is I'm talking about oral, I'm talking about patches, I'm working with them on what they want, but they may need combination. And while you can say, look, nicotine use during pregnancy can affect the baby, but you're already using nicotine, what we're looking at is a short, sharp treatment that can actually assist you to change this, and nicotine on its own is safer than smoking. You know, so it's a tricky one because they don't want to do their babies any harm, but you do need to support them so they can change this really, really sticky, addictive habit. So, you know, you start off with behavioural stuff, you start off with the short acting, but don't hesitate to go to the patches and the short acting together if they cannot stop, because it's really important that they do. Moving on. And when people stop, yay, congratulations. Even if people stop for a few weeks, fantastic, it's great that you did that. And what are you noticing? What has changed? What are the benefits that you're noticing? Looking at how they might manage the triggers. If they're going out with their mates for a drink, that's the time they always smoke. How are they going to manage that? And if they do have a lapse, how are they going to manage that? People very commonly will say, oh, I had one cigarette, I'm useless, I'm hopeless, I failed, and then I started smoking a whole packet. I would always say to them, okay, so you've had a lapse, but what do you want to be? Do you want to be a non-smoker? Look upon this as a learning opportunity. How did it happen? How can you support yourself to not do this? And let's get back on the horse and start riding again to become a non-smoker. Next one.
We've got 6 minutes left, Hester. Did you want to, instead of jumping into the resources, did you want to look at the case study of John?
Yeah, totally.
Perfect. Let's...
Because the resources don't, so they're all there. You can take a look at them. There's beautiful things there, both for providers and patients. Okay, so Johan, history of alcohol dependence, recent withdrawal in hospital, now on acamprosate, 666 milligrams TDS, not drinking. He's on 20 milligrams BD for his oxycodone for back pain. There's a whole issue there around what needs to happen with him there. Long-standing depression, high blood pressure, high cholesterol, and previous AMI. He's been smoking since age 15 and wakes during the night to smoke. His carbon monoxide, it is 50 parts per million. So how do you approach this? Tim, how would you approach this?
What a great question. This sort of case actually feels quite familiar in its complexity, where the sort of thing I would do would be talking to him, seeing what he wants to do first of all. Where does he feel he's at? What does he want to work on? What's contributing to each other? So that back pain, I think, is significant, and is on oxycodone for that. He's had withdrawal in the hospital, so I see, and he's not drinking, so I congratulate him for that. He's made a really good start. I'd want to know a bit about that past history, including the depression, because that's going to play a great deal into his ability to sort of think through what he wants to do and make decisions around that, and feelings of guilt around perhaps not being able to achieve it, or not being confident that he can achieve it. He wakes during the night to smoke, so he is significantly addicted to cigarettes there. And so we're going to really have to work on that. He's going to need help to get off the cigarettes. And he's already started with alcohol, which is fantastic. We have to consider the role of the oxycodone as well, whether he may well have an opiate addiction going on too.
Yep, absolutely. Absolutely. And certainly that CO of 50 parts per million, he's got a significant nicotine dependence. So it's a surrogate marker with the amount of carbon monoxide in your blood as a surrogate marker for your nicotine dependence. So for someone like this, you can use the combined NRT, you can use varenicline. I would put the bupropion on a very distant second. You could look at using both of those, but once again, working with him around what does he want? What does he want to achieve now? What are his worries? And I would certainly be looking at with him, has he tried to give up smoking before? It's very likely that he has. He may have had really times in his life where he's had years at a time where he hasn't smoked and he's had really good success, or he may be someone that has never successfully in his mind stopped. And so you want to support him. He will need a lot of support to actually change this. And the other thing is with the oxycodone that he's using, you may find that once he stops smoking, that he doesn't need as much, that his need for the oxycodone will actually go down. But you're absolutely right to flag the issues with dependence. I think we're finished.
Marvellous. We've got about 3 minutes left. I'll just fire through some of the questions for you as well. A couple of questions around using cannabis as well. So if a pregnant woman is using cannabis, what you might do, and whether medicinal cannabis has any effect on quitting smoking.
The medicinal cannabis issue, look, this is really unclear. There is really not a great deal of evidence around the role of medicinal cannabis, and certainly smoking any burnt organic matter is not good for you. The role of cannabis in pregnancy is controversial. The bottom line is ideally what you want, if you've got someone that's using cannabis and nicotine, you want to help them give up both, and doing nicotine, using pharmacotherapy for nicotine will help them. We don't have good pharmacotherapies for cannabis, so they do need to go through cannabis withdrawal if they have a dependency. Lots of support, lots of encouragement, helping them to build their skills and their motivation are a really important part of that.
Lovely. And a final question, which I suspect we're all expecting. What's the role of e-cigarettes?
Yes. So I think that e-cigarettes can be very useful in a very high-risk person, very highly nicotine dependent, has not succeeded smoking cessation through other means, that e-cigarettes may be a harm minimisation for someone like that. Just need to flag that they're currently not legal. You cannot legally buy e-cigarettes with nicotine in them in Australia. You have to import them as a smoker yourself. I have to say that what we see is that people will use their e-cigarettes and they will continue to smoke, but the reality is that they may well be cutting down the amount of tobacco, which is a good thing. I have to say that I am concerned that we really don't know what the long-term risks with e-cigarettes are, and I am concerned that they are becoming popular and cool with young people. I am concerned that there are people that can make money out of moving people from tobacco to e-cigarettes, and particularly another generation of young people who are using this cool thing called Juuls or e-cigarettes. That is a concern. But they do have a place, and there certainly are some of my patients where they have tried really hard every other way. They are high risk, where it is a harm minimisation approach to assist them to use e-cigarettes. I just haven't found that it's actually particularly assisted them to stop completely, and ideally that's what I want to do, is move them from the e-cigarettes to actually stopping completely if I can.
Marvellous, thank you very much. We've hit the 8:30 mark, so if we put up the learning outcomes again, I hope that we've achieved all of those learning outcomes. Thank you very much, everyone, for your attention and for your questions that have come through too. You can see the learning objectives there. I think we've achieved all of those. Thank you very much, Hester, for an excellent presentation tonight, and thank you as ever, Sammy, for running all the technology for us and coordinating us this evening.
That's wonderful. Again, a big thank you to Hester and Tim for presenting for us this evening, and also to everybody that joined us online. We really hope that you enjoyed the session and enjoy the rest of your evening.